they're saying. Okay, so what we're going to do today, and I'm glad the students have come, I'm glad the residents are here, and I'm glad the faculty is here. We have been evaluating our student education for the last several years. One of the things that Dr. Olive and the Medical Student Education Committee have been working with are not only the objectives of the clerkship, but also the dissemination of the information with regard to the clerkship. Thank you. So with this particular Grand Rounds, we have objectives to go over. The first thing that we have to understand is that we are not in control of this from the standpoint of why we are doing it. The Liaison Committee on Medical Education, LCME, reviewed Quillen College of Medicine a couple of years ago. There were serious concerns in regards to our handling of Medical Student Education Committee. It has been revamped and reorganized. There has been a full curriculum review over the past several years. They are presently in year 4 where all of the curriculum has been evaluated. The curriculum had to be mapped for each clerkship, and with regard to that clerkship, it had to be mapped to certain objectives. Thus, my request of the faculty, when they give a lecture to the students, that there be 3 objectives and a bibliography so that we can then map those lectures to the curriculum, and it's taken into a full database to look at what we're doing. Likewise, to understand our clerkship objectives. And to understand our clerkship objectives is to understand the philosophy behind what we're trying to do in medical student education at the present time. Likewise, the last is to look at these professional expectations of students and our residents and faculty in the assessment of how we're training and educating our students. So it is a combined discussion. Likewise, today we will go over our clerkship objectives. We'll go over what's required of our students with regard to patient encounters and procedures. We will go over the clinical expectations of our students. We will go over professional expectations of our students, the student mistreatment policy, the role of the resident in student assessment, and you can put that role of resident and faculty in student assessment, as well as teaching and assessment skills for development of how we're going to help our residents teach our students. Why am I doing this? Why is this happening? This is the ED24 standard for the LCME. It says, an institution offering a medical education program, Quillen College of Medicine's, residents who supervise or teach medical student and graduate students in biomedical sciences serve as teachers and teaching assistants must be familiar. And the key is here, it must be familiar. And in our past, we've not made this as well known. Likewise, you have to be aware of the objectives as well as be prepared for your roles as teachers within the clerkship. Now, about 2.5 years ago, as I started to make changes within the clerkship, I asked for a simple thing. It's a simple little thing. I asked the 8th clerkship students to give me a history and physical, just a written history and physical of a student, of a patient, just to give it to me and just so I could see what they were doing. Half of them didn't have an HPI. Half of them didn't have a physical exam. One put the physical exam in the HPI, put the review systems in the physical exam, and had no assessment or plan. it came to my attention that we were not teaching our medical students what was going on. Subsequently, MSAC as well as LCME started to recognize our deficiencies. This is the new standard. 9.1, preparation of resident and non-faculty instructors. Again, it has verbiage with regard to supervision. However, the key phrase is now, the medical school provides resources to enhance resident and non-faculty instructing teaching and assessment skills, and provides central monitoring of their participation in these opportunities. That means I can't just send you a syllabus and know that you understand what we're doing in the clerkship. I can't just say, there you go, guys, good luck. MSAC and LCME no longer will allow us to do that. So today's exercise is to put you in an understanding of what objectives we give to our students and why. So, one of the things that Dr. Block and I have been working on has been the supervision as well as teaching by the residents of the clerkship. Our mission statement, it is an important goal of the Department of Obstetrics and Gynecology that medical students have a positive educational and professional experience during their OBGYN rotations. That is our mission statement for our clerkship. That's what we're striving to do. It means that everyone, residents, faculty, support staff, clinical staff, have the same opportunity to enhance or detract the medical student education. When I saw that the H&P was not being performed in a manner that would be conducive to good patient care, I recognized that our product that we were producing wasn't up to the standards that we felt we were attaining. So I started to look around for, I apologize for the word, old school way of doing things. So we made the concept of a history and physical very important. Turned out there were other people in the United States thinking the same thing. And they developed a series of objectives called Entrustable Professional Activities, EPAs. And what the intent of LCME is, these EPAs are those types of things that a resident on the first day of residency should be able to do unsupervised. So that means the first day they take a step into a hospital with the MD after their name, they should be able to do these activities without any supervision. Subsequent to working with these EPAs, the objectives mirrored what we were trying to do with regard to student education. It is my philosophy that I've put into the clerkship that what we're trying to do for our students is to create a product that on July 1st of their graduation day and entrance into residency, they can do all of these objectives without any supervision. Now, obviously, we all know you never get sick on July 4th of any year. Stay away from the emergency rooms, stay away from hospitals. However, what we are trying to do with our 6 weeks, 42 days, and if you count the days we really have them, it breaks down to 38 days that we as a department have access to these students. And in that time, we not only need to teach them obstetrics and gynecology, but we also have to prepare them for July 1st. So we're going to go through the clerkship goals and objectives. Our goals, as enumerated in our small booklet that we give the medical students each rotation and is online for perusal if you'd like to have it, are the following. To develop a solid foundation of medical and surgical knowledge regarding the care of female patients. To participate effectively as a member of a team caring for female patients, and to develop your personal medical and surgical skills to improve your abilities and the EPAs as you progress in your residency. So that is our goals. Our objectives follow those, but they are more broken out. The first one is to gather a history and physical. Simply to gather a history and physical. Now, we would like to discuss the ethical, social, and diversification perspectives. But bottom line is, everybody should be able to do a competent, well-written out history and physical when they walk out of medical school. That's what we're after. Likewise, a differential diagnosis, and these are the types of conditions that we talk about. Obviously, in 38 days, we can't expose them to everything that we have been exposed to in our 40 years of education and experience, but we are trying to get them to understand the differential diagnosis that would go with that. Likewise, those common diagnostic and screening tests that we have for our types of issues, including fertility, urogynecology, and gynecological oncology. If they don't understand the tests, if they don't understand what we're doing, even if they never, ever deliver another baby, they still have to be understand and to be able to interpret certain testing that we know they're going to be getting as doctors that take care of should be more, okay, good, all right. Likewise, we want them to be able to create patient orders. I realize that we now have CPOE. I understand that. I'm not so old school as not to understand they already have order sets. But as I tell the students, who makes the order sets? Does some objective aspect up here just sort of reach down and touch the order sets and they're created? Doesn't happen that way. Each one of the faculty has served on committees that has created order sets, had input into order sets, have added their 2 cents to those order sets. Just saw another order set that was created. So as the students have to get through this, one of the objectives is to write a set of orders. And yes, it's old school writing it in longhand, but it also gets them to understand what types of things need to go into orders. Writing a prescription. Yes, we now all e-prescribe. But if you don't know what's going in there, then how do you write a prescription? So another objective in our clerkship is teaching them how to write a prescription. One of the places we can start to work with these is when we're in the clinic, and even though we're e-prescribing, have them write you a prescription. Document a clinical encounter, either electronically or written format. We've got in that small booklet multiple notes that we need to be able to have them perform so that they understand how there is a difference between an admission note, a labor note, a clinic note, trying to get them up to speed. And then accurate and concise oral presentations. We've been struggling with how we evaluate, but I will guarantee that every one of you, both residents and faculties, listens to a student daily present a case to you. That is an ideal opportunity to give feedback immediately so that that person will understand what needs to be done so they can present in our language. To digress slightly, this rotation, in my opinion, after looking at all the rotations, is the most difficult for the students. It's the most difficult because there's no way they can prepare for it. Our physiology is not normal. When you get to Dr. Block and Dr. Welt, the physiology really goes off the tracks. But the physiology is not the same. Moreover, there's no way to prepare them in the first 2 years for what we do. Hours and hours of boredom superseded by moments of sheer terror. Likewise, there's no way they can understand the terminology. This is a 32-year-old white female G2 P2001 who presents at 39 and 5/7 weeks. They can't get that. And we asked them the day one to be able to figure that out, much less fetal heart rate monitoring. So we have the opportunity to work on oral presentations, because the foundation of what we do as doctors is communication. Every time we talk to another colleague, we've got to communicate in a way that doesn't harm that patient. If we don't communicate as physicians, if we don't teach the students how to communicate, we're putting subsequent lives at risk for our poor communication. Likewise, the concept of an interprofessional team. The concept of education in today's society is team. Not only just doctors and nurses, but pharmacists, social workers. In our clinic, we have a social worker. In our clinic, we have a dietitian. Team approach to working. We also ask them to recognize urgent care, including acute abdominal presentation obstetrical emergencies. Some of those moments of sheer terror when the cord decides to visit the vagina before the baby does. Those sorts of things we need to be able to get them to understand. We talked today in CQI about informed consent and the impact on the patient. These are things that we're trying to get them aware of. And to identify the procedures we do under direct supervision. There are things, as we'll see, that we want them to be able to do. Your supervision is going to be able to do them. And an understanding of systems-based practice. The biggest thing that's in the literature right now that I see as an administrator is patient safety. We are in the diagram of healthcare reform, but the biggest thing driving healthcare reform is not only access to that healthcare, but access to safe healthcare. There was another article out that was a takeoff on To Err is Human, the 1999 article that says we as physicians kill 100,000 people a year. That now number is 250,000 a year in all hospitals with regard to what happens. So, what do we require of our clerkship with regard to certain procedures? We ask them to be able to do a KOH prep, likewise a wet mount. So if you get the opportunity during our clinical times, I encourage you to involve the student with this. Likewise, to perform a pap smear. We in surgery are the only two that require suturing by the medical student. While we do a surgical skill lab, and I thank the residents who have worked with us with regards to utilizing our beef tongues and utilizing suture to help them suture and learn to suture, it is only as they are part of a team that they'll be able to attain this. So look for the opportunities. The other ones that we require, basic heart rate field tracing interpretation, a labor note, obstetrical note. We do 3 evidence-based presentations. We do 1 obstetrical topical discussion, 1 gynecological, and Dr. Welt does an extensive medical surgical complication of pregnancy that is well received by the students. There is a mid-clerkship review with the clerkship director, exam under anesthesia. But the one I'm going to hone in on is the old school one. We need these people to get feedback with regard to doing a history and physical. It is important to give them the feedback so that we, who might be that patient on July 3rd in the ED with some type of illness, will have confidence that a Quillen graduate will look at us and go, hey, you used to teach me obstetrics, but then be able to do a history and physical. The ones that are not required, but we offer and have, obviously, ultrasound, spontaneous vaginal delivery, hysterectomy, laparoscopy, low transverse cesarean delivery, and certainly optional, episiotomy and laceration repair. These used to be, these have been changed over the past year because it used to indicate that they were supposed to be able to do a hysterectomy. We kind of figured that probably was a little out of their league. Now, with professional expectations, this is online, this is in their book, and if you all would like a copy, we will make sure that you receive a printed copy. thing I really want you to understand, besides the concept of respect, punctuality, limitations, personal accountability, ethical principles, is this part right down here bolded. Students may fail a clerkship solely based on unprofessional activity. Medical Student Education Committee has taken this to another level as well. If you feel that there has been unprofessional activity by a student, there is a form that can be created that you can turn into MSEC for further evaluation. What MSEC is saying to us is we're responsible for their professional behavior. If there is unprofessional behavior by a student, it is our duty to report it. Now, we would hope that that would not happen, but I can assure you that as a clerkship director, I have heard of other clerkship directors having difficulty with certain students. And yes, students, we do talk among ourselves. So we know what's going on. We know who we have to watch very carefully. Likewise, these are examples of unprofessional activity. This includes absent from duty without excuse. There are times when you do get an illness. I remember my pediatric rotation for the 5 out of 6 weeks that I had an illness. An illness that kept me, for the only time in my medical career, unable to work. Thus, I'm not a pediatrician. Likewise, any type of behavior such as this that causes us to get concerned, we need to make sure that we either notify the clerkship director, notify the chairman. If the clerkship director and the chairman are not responding to your concerns, you have the perfect right to talk to Dr. Ken Olive, who is the executive assistant vice president in charge of student affairs. Texting or sleeping during didactic, clinical, laboratory activities. Which one of those are you doing?
Everybody here has done one of them. That's a little tough.
That's a little tough?
Yeah, I think everybody here has done one of them.
I think what it would say is that a chronic abuse of utilization of electronic devices during activities that are designed to educate you would be inappropriate. Being up all night and somehow going to a didactic and falling asleep and hitting your head on the table might lead you to be able to go home and get some rest. Oh, and by the way, just for the sake of argument, yes, Dr. Rich.
I will say, in all seriousness, I've had a student text.
Yes, and that's part of what we have to correct. And we have to model behavior as well. We shouldn't fall asleep during their didactic material, which has happened. Yeah. So, and now I lost my train of thought, but that's okay. I'll go on. Okay, now for the other, this does go to it. How many people are aware that our students have student duty hours? I got 2 hands that went up. Our students have the same 80-hour work week duty restriction that all of our residents do. The difference is they do not have the same restrictions as our PGY1s. So therefore, we are able to utilize them in our night float in a system that goes on with regard to that. And if I think there is, yes, hours of in-house call count towards 80 hours total. This is the in-house. There was something that I had to get because we are the only individual rotation that utilizes a night float system for a week. So I had to get a special dispensation from MSEC to allow the students to work in the hospital for their 80 hours on a weekly basis. Other rotations have them on call one night and then off several nights, but we're the only rotation that gives them a night float. But 80 hours, and we calculate the 80 hours. Since we've instituted the night float, we have not had any instance where a student has overworked 80 hours. And prior to our institution, we had 3 or 4 instances where we were working them over if their call backed up too close together. So we're having to watch that very carefully. But they do have duty hours and need to be watched for that. This is effective as of July of 2011. It is still ongoing at the present time. Now to the tough part. One of the difficulties with feedback, one of the problems with making that feedback, and yes, Dr. Block, I will ask for it to be done on an app on your phone, is the fact that we have to evaluate each other. I'm going to take another diversion. In my role as an administrator, I understand that my boss, the dean, basically evaluates me every day because of how I present myself. But I meet with him every week. And basically, I get feedback every week from him in terms of how I'm doing my job. But every year, I am required to perform a 360 evaluation in which I ask those people that I supervise and who supervise me for their evaluation of me. And it is an hour-long evaluation that I have to go through. So everybody at every level gets evaluated. You may not know this, but the dean gets evaluated by Dr. Bishop, who's the vice president of healthcare affairs. We all are evaluated with evaluations. The students will get a chance to evaluate the residents and the faculty, and we actually do that in 2 ways. One, we have them fill out forms when they finish the rotation. So they're filling out forms. They also then are required by MSEC to fill out an anonymous evaluation of residents and faculty that we will not see until the end of the year. So we have our evaluation ongoing from them. Therefore, it behooves us to give them feedback in a reasonable, timely manner. It is part of our job. We chose to work in a medical school where there's medical education. We chose to be here teaching the next generation of physicians. We chose this job to make a difference for the future. Part of that job is our evaluations. Last year, this is how our residents, don't feel badly, I presented the faculty with their report card yesterday. So we will try as a group to improve our evaluation of students going forward for the next year. We will also try to make a better product. And hopefully that product will then deliver. Oh, wait a minute. I got one last thing. The residents together have come up with 3 goals. The residents have decided that they are all going to answer at least 500 true learned questions before the 2017 CREOG exam. And just for the sake of discussion, residents, I got my own login for that. I'll be taking questions also, and we'll be competing against each other. Nah. It's only fun until somebody gets hurt. All residents are going to score greater than 190 on the 2017 CREOG exam or increase their 216 CREOG scores by 15 points. And all residents and faculty will treat each other with respect and accentuate positive experiences. We are having these made up and laminated and placed on their lanyards and my lanyard. It's 10. It's 10? You want 10? We have some disagreement. We'll work on that. But as I was saying, if we can teach our students and our residents can teach our students, maybe we can have this as an outcome. These are my twin granddaughters who are now 10 months old. Thank you for your attention. Question?
So on evaluating the student efficiency in the past, the students could get on the all scripts and they could do a special note. And on this rotation, the students don't know how to do that. Is it no longer available or?
It is available. I think that they have logins. We can work with them. What I have found is that most of them utilize labor and delivery where they get their H&Ps. There is one other place that they're being evaluated. Since I'm not on labor and delivery, but I meet with them at their mid-clerkship evaluation, we go over a written history and physical at that time. But there is feedback to them. What we're asking for is more feedback. So if you want to do it electronically, we can work with them.
Yes, if we want to do it in the office, the students have to be already know how to do that.
Right. Well, then there are people that will help you with that, Dr. Olson. Any other questions? Again, thank you for your attention.